Hello and welcome to the Insights Overflow podcast, episode 6. In today's episode, I chat with Jan Swanepoel, who's the co-founder of Pennant Consult. They specialize in leveraging Bluetooth and IoT technology to capture data of patients within hospitals, to better manage customer experience and better allocate hospital resources. I hope you enjoy this episode of the Insights Overflow podcast, and thank you very much. Hello and welcome to the Insights Overflow podcast. You're joining me on episode 6 today, and today I'm joined by Jan Swanepoel, who's an anesthesiologist and the co-founder of Pennant Consult, who specialize in leveraging IoT solutions within the medical industry. Jan, welcome to the Insights Overflow podcast.
Thank you. Thank you very much for having me, Andrew.
The first question I want to ask is, an anesthesiologist. What is the difference between an anesthesiologist and an anaesthetist?
That's a very good question. It's not written in stone, but generally in the South African context, we would understand an anesthesiologist to be someone with a postgraduate degree in anesthesiology, a specialisation, and who has written and completed the fellowship of the College of Anesthesiologists of South Africa's exams and registered with the Medical Council as a specialist. An anaesthetist would refer to anyone that provides anaesthetic services, and that could be anyone from a general practitioner's perspective to someone with vast experience in providing anaesthetic services in South Africa. So that would be the difference.
Okay. And I think, you in a very unique position in that Pennant Consult obviously has a focus on technology within the medical industry. But you obviously come from a medical practitioner side. So maybe you could describe exactly what Pennant Consult does and specifically what you guys are trying to achieve with the Sense platform that you guys are developing.
Yes, thanks, Andrew. So we have seen an opportunity in the healthcare environment in leveraging data to enable better access to healthcare and to also protect our resource in healthcare and provide better patient care. And so we are trying to collect data in a non-human manner, which will inform our day-to-day operations in hospitals and facilities to provide better care in the end of the day for patients in South Africa.
Okay, and if I was a patient coming into a medical facility, a hospital or a day hospital, how would I actually interact with the Sense platform? What would the Sense platform ask of me as a patient or as a medical practitioner? What would it actually do for me sort of at the ground level? Maybe describe, what that IoT-ness of it does.
Okay, so what we essentially do is we track patients and assets in a facility in a real-time fashion. So when a patient arrives at a hospital, they will, as part of the other tags that they would normally receive when you go to hospital, they will receive a location tag, a Bluetooth tag, which will then track them on their journey through the hospital. And it will then build a picture for management and for operations to see where are the delays, where can resources be deployed better, how much time and resources are being wasted in the facility, and how can we actually optimize the use of our really high volume areas like theatres and like diagnostic areas in the hospital.
Because, there's a technical constraint in that there's only so many theatres. So you actually got to optimize the use of those theatres as good as possible. So any idle time, I suppose, is a lost opportunity.
So it is a lost opportunity, but it's also a lost opportunity for using our resource in a more effective way. So it's nurses, it's healthcare professionals, it's allied healthcare professionals, it's actually the physical facilities and the infrastructure that we would like to optimize the use of, and thereby create better access for patients to healthcare in South Africa.
And I suppose, from a patient perspective, say I'm going in for a particular procedure, as a patient, would you necessarily have an idea of how long you'd be in the different stages of your triage? I don't know what the correct medical term is, but say a big thing is probably, say, expectation management from a patient point of view, because, if I get stuck in, some sort of pre-procedure step and I've got to wait till when the doctor realizes I'm still there, that ability to collect data where that patient is in the different steps, I suppose, allows the better expectation setting from a patient point of view that, by this particular time I can expect to be out, because you can accurately measure them throughout the process. So one of the benefits then is actually then measuring what you expect, how long you expect the procedure to take, and how long the procedure actually takes. So to me, then that visibility that the patient receives, I suppose, and the doctor receives is a huge benefit, because you never know what can be missing sort of in the process. Somebody might forget about you, hopefully not. I suppose, are there standard times for specific procedures that you're sort of measuring against? And also, does the medical industry, say, actually want to optimize, or they're quite sort of happy where they are? What is your perspective on that?
Okay, so that's a very long question, and there's going to be a long answer for that. So from my perspective as a healthcare professional on the ground, probably the question that I get asked the most, even today, is, Doctor, when will my procedure be? What time? And what time will I be going home?
Okay.
And after 30 years in the industry, I still cannot answer that very accurately. I can give you within the closest couple of hours.
Wow.
So that's the first perspective. The second one, this is a very vulnerable time for patients. And for any person. If I go to hospital, I'm quite nervous and vulnerable. And so especially the uncertainty and the inability to control your time and your day that is lost is now in the hands of complete strangers. For an example, we did in one of our hospitals, we did a trial where we looked at patients that rated the hospital poorly. So we went to look at their journey in the hospital.
Yeah.
And we saw that patients that rate the hospital poorly have one specific thing in common if you look at their journey, and that is that they spend a considerable amount of time lying in front of theatre. And if you think about that, that is a very, very vulnerable time. You are going into theatre, there's a lot of activity, it's quite busy. And for patients, that is a very, very bad experience. And that was quite enlightening to management when we pointed it out. So it's that kind of thing. Regarding the measuring of the procedures, we would like to use that as a benchmark, but definitely no kind of standard. Once again, my experience has taught me that when you're in theatre, when you're working with people, no one really watches a clock. No one tries and races through procedures and see how quick they can do it. We work effectively, we work efficiently in theatre, but the concern is obviously our first priority is always to do this safely and comfortable for the patients. So in no way do we want to set the standards in terms of procedure times, because then it becomes a stick, and that we would not want to do. What it does allow us to do is see that our areas are used more optimally, so we can manage our bed availability and bed management and admission process a lot more effectively, because we can say which beds will be available now, which beds will be available in the near future, and how do we admit patients into that. And then also our discharge processes to how to get patients safely and comfortably through their post-operative period and discharge them home, and thereby also improving their communication, because that's what's lacking in healthcare is patients would be lying in areas and they're not knowing why and how long this is going to be. And this system allows us to predict how long you're going to be here, what time your people can come and actually fetch you from the hospital. So it improves that communication. There are definite standards in the industry regarding efficiencies in hospitals. And we follow the standards of the director of anesthesiologists in America. They have a standard handbook and definitions for this. And in South Africa, we have our own standards, which is aligned very closely to this. So we do try and use these benchmarks and benchmark our own processes against against this, but there's not a lot of work done and specifically categorizing the types of wastages in healthcare. So there's no kind of standard term for if a patient would lie for very long in the post-anesthetic care unit, for example. And I think it's also because of the uniqueness of healthcare. People are different. No one reacts the same to any kind of procedure, and we have to be adaptable to it. But it does allow us to see a bigger picture and see, well, we can do better in these areas. And change is all about changing small things often. And so I think that visibility allows us to do that.
It's a very high touch industry. But I suppose, if you look at it, without collecting the data, there would be no real way of measuring that. So even if, say, you don't want to use it as a stick, but you even just wanted to ask the question, without collecting the data, you can't even ask the question, how did this patient's journey look like? So is there any way that anybody's even collecting this data right now, or is what you're doing with the Sense platform sort of truly groundbreaking in terms of its way that it automatically collects the data? Have you seen anybody trying to do this even manually?
We'd like to think no one else has tried it, but it's not true. So with our proof of concept, we started off with asking the facility where we did it about their subjective opinion on patient journeys and stays. And we asked them questions like, how long do you think the patient stays in your ward afterwards? How long do patients stay in your reception area in theatre? How long does your admission process take? And that was very, very insightful for the facility.
Yes.
Because they were completely off target in their subjective assessments about how long it takes. So that is our South African perspective. Definitely all the groups, all the hospitals are collecting this data at the moment. It's a manual process. It's been done on spreadsheets. It's very labor intensive. It does not give you any real-time visibility. At best, you will have 2 to 3 months visibility of past processes.
Sure.
That's in the South African context. There are definite, very smart people out there that are looking at these solutions and working it. And I think there's a real understanding in healthcare in South Africa to improve the way that we deliver healthcare on this level, not many other, but specifically on this level. So there's definitely a kind of a will to start looking at efficiencies and start improving it, because we're not building more hospitals, we're not building more beds. We need to use what we have more efficiently. And I think COVID taught us that you can have 300,000 ventilators, you can have 500,000 ventilators, but if you don't have the intensive care nursing staff to look after patients, you don't have the specialists and doctors and physiotherapists and dietitians to look after these patients, it's pointless, and we need to use what we have better. So definitely there's a will to look at and changes. Yeah. So what we're offering is we're offering nothing new. We're just offering a new way of collecting it. So no humans involved, no manual data collection, and it provides us a real-time visibility of processes, what's happening in the hospitals.
Yeah, I think to me, the two types of industries that affect our daily lives or can affect our daily lives the most is, say, healthcare and technology. Because, we all get sick, we all need certain procedures. And then from a technology point of view, technology has basically permeated our entire lives. But one interesting thing is that the medical industry is a relatively slow adopter to new technology. But I do see some inroads. My own personal experience, say my son was born 4 years ago, and, you arrive at the maternity ward, you fill in a couple of things on paper. Then just over a year ago, my daughter was born, and they were filling in everything on iPads, which was quite interesting. And, sort of seeing the same doctor who previously did it on a clipboard now has to do it on an iPad, and the process on the iPad, say, was a lot more regimented because there's certain steps that one had to do. So even in the 4 years since my son was born, I've seen those changes sort of directly. So what's your assessment on, how the medical industry adopts new technology, and what are the barriers to entry? Because it always seems so obvious. This can improve healthcare, this can improve patient experience, but at the end of the day, you've got a relatively conservative industry that has to put all its focus in helping people and not necessarily being the first adopters of technology. But there's so many opportunities for technology in the healthcare. So what's your assessment of how the industry adopts technology and some of the challenges that you've faced in talking to hospital groups about what Sense does and the benefits it can provide?
I think it is a very exciting period for everyone, for healthcare practitioners and for hospital groups and for funders and for government and for regulators. And like any other industry, the whole vast availability of data. Traditionally, changes happen slowly in healthcare, and there are good reasons for it. We come from a biological background. We look at we look after biological beings, and we know that changes are slow, that anything you do has an effect, that people are not the same, that people react differently. So that will automatically translate into our adoption of any new technology. We most probably a little bit suspicious of it. I think there is that, but there's an exciting generation of people who are very eager to adopt new technology. So that's the first thing that has to be saying. It's our perspective. The second thing is that there are a lot of, wouldn't say barriers, but a lot of conditions, and this is for safety. I think currently in South Africa, the biggest concern around adopting electronic or IT or tech in our industry is security, and regulators and funders and hospital groups are currently sitting and formulating a response and standards for this, which is quite exciting, and it creates a lot of kind of standardization and certainty in the industry. So there's security is a big thing, and data security. There's obviously the patient perspective of his data and where and how it gets managed and who's managing it. So there is, I wouldn't say a lot of red tape, but a lot of boxes that need to be ticked. There's a lot of regulation. Even our own medical council has got recommendations around electronic health records, for example, and the deployment of tech. So all of this needs to be carefully considered before you employ any new tech. And I think also there is maybe a little bit of uncertainty about how data can help us. Just to collect data for the sake of collecting data doesn't necessarily make any sense from a financial or patient care perspective. You need to very carefully ask yourself, what questions are you asking? What questions do you want answered? And I think that hasn't quite been formulated very well. And this is not a South African phenomenon. This is a worldwide phenomenon.
Yes. Yeah. And, our paths crossed when, obviously you set out, you've got a couple of other co-founders within the business. They from a, say, more engineering perspective, so you can sort of argue that, the meeting of the minds, between you and your co-founders from a medical and technology point of view. But, how I understand Sense, I'll sort of paraphrase and you can sort of tell me if I'm right or wrong. But, me as a patient, I'll go in with a specific Bluetooth tag. That tag will then correspond to specific beacons inside of the physical hospital or day hospital or sort of procedure facility, whatever we want to define it as. And that beacon will then pick up that you're in that particular zone, and that zone is associated with a point in space. And then you, as a patient, have got a sort of a determined journey that you should follow through those beacons. And then the beacons then automatically measure the time spent in that particular zone. And as you move to that next zone, it sort of tracks you through the process. Have I got that sort of correct?
Yes, that's in a nutshell.
In a nutshell.
I think as healthcare providers, we're not very keen on the term predictive pathway because we know things aren't that predictive.
Yes.
But we do have a set of standards. So we know what the length of stay, and that's a term that we would use in the industry for specific procedures would be. And our system can then pick up if your length of stay is slightly long or short, and someone can address that. It'll alert a certain level of management. We give bed level specificity in terms of location, so the tech is quite specific around that, which allows us to manage individual beds and update individual beds. On a very simple level, it can find patients in hospitals, and this may come as a shock. But if you look at our facilities in South Africa, acute facilities of 200 beds and upwards to 350 beds, admitting probably about 60% of them turnover on a daily basis, each patient with a different journey and need to be at different places, it becomes quite complex, and you use a lot of human resources to manage it. So the system allows you on a basic level just to say, well, where is everyone at this specific point in time without losing patients.
Yeah.
And it allows us to also say how well certain care areas in the hospital are being used. So is there a delay at reception? Is there a delay in the ward? And it creates priorities in areas. So we would, for an example, we would have a theatre list, which is a list of procedures in a specific theatre for that day. And that will be on our system. And so it allows a ward to know which patients are going to theatre next. And our system dashboards will highlight that. And the ward sister can actually walk into a ward and immediately see she needs to attend to these 2 patients now who will be going to theatre next. And if you change any order on the theatre list, for example, it'll change her priorities down the line. So there's reception. People know that this patient now enjoys priority in being admitted. The theatre, the wards know that this patient enjoys priority now to being admitted, and creates those kind of better communication between the different silos in the hospital.
To me, I hear a lot of similarity between route planning in logistics. And I think that sort of brings me to an interesting point, is that, one of your sort of fellow partners or co-founders, I don't know quite sure how to define him in the space there, but we engaged on a project that he was business that he was working on, and actually sort of introduced OQLIS to you guys, having seen what we were doing in the routing and planning. And I suppose if you think about routing a patient through a particular process, I can understand why he could, from a product point of view, really sort of flesh out how the system works. But then obviously he saw that, there's a need to communicate this data to people in wards through dashboards and sort of visualizations. So, maybe in a nutshell, you can sort of describe, how you guys and how specifically Sense leverages OQLIS and its sort of unique features to help you in your journey to create that better patient healthcare provider experience.
So, our journey is a fairly long journey, and it has many components. We had probably right in the beginning of our journey, we had to make a decision, and we wanted to build the best product possible, and we decided to get the best people in the industry for all those specific components. Definitely very challenging to us is the technical aspects of getting the data from a SQL database or cloud database, what we use, onto a dashboard. And that is that's a unique value proposition. There's a lot of work that goes in that, and as a healthcare professional, I don't even really appreciate that. But if we were to develop that tech of getting our location data into a workable dashboard, which creates the priorities, which creates a location and creates intelligence that we need, it would have taken us years again to do that. And I think that's where OQLIS definitely came on board for us, in cutting that time to market, and also understanding machine learning and AI, which is a fairly nebulous concept to me.
Yes.
So they definitely cut that time and that effort for us. We may never have gotten there without that input.
Yeah, I think that sort of brings me to an interesting sort of area, is that, people are talking a lot about AI, sort of machine learning, and how that can help them. But if we had to have this conversation in 15 years, 20 years, where sort of AI or machine learning has sort of become more ubiquitous, what do you think the future would look like for, say, a solution like Sense? And what is your ideal, if you had to pitch sort of what that ultimate solution looks like from a Sense point of view?
I think for us, the ultimate solution would be AI-enabled bed management system that not only does in-hospital tracking, but that we allow to track people in different ways, pre-hospital, so that'll be through records or through their visits to their GPs. And I think that's where the world is moving towards, is pre-hospital tracking. And when you do that, then you can start predicting what resources you need and how you're going to deploy those resources. I think that's where one would want to be. And then in-hospital tracking, obviously, is the management of the bed, managing facilities, and specifically managing of resources. So in the beginning of our journey, we were asked if we would track healthcare professionals and sisters. And we declined because we felt that changes the nature of what we want to achieve. So the challenge in the future would be, how would we track healthcare resources without them feeling that they are being watched? And as the technology evolves, I think that will be possible. But specifically, pre-hospital and in-hospital resource management and bed management. And I think AI has a lot to offer in that area.
Yeah, I think the complexity is that, for AI to exist, or say a machine learning algorithm to exist, it needs data. So one has to collect it. But it also comes down to how you, say, position a problem. And, one thing that's evident is that, AI isn't sort of one general, one size fits all. It's usually very specific in its use case that it's trying to solve. But without data, it cannot do anything. Without automatically collecting the data, you sure can't do anything. So that's definitely where I see a solution like Sense, is that, if you can build up a history of, say, what procedure, time of day, season of the year, time of year, and you start building up that history, it becomes more of a realistic benchmark to sort of measure against. That might be better than, say, like a straight average, that says, on average, you came in for this procedure and it should take you 4 hours till you're in the recovery ward, but it might be that it's a particular busy time of the year, and seasonally that might be the case. So one can't also track against sort of static averages. There has to be sort of this dynamic, sort of machine learned aspect that sort of captures the nuance of that time. So I definitely see that playing a part in the future. And, and I think, we also hope that somebody somewhere, maybe we put this to the medical aids, that somebody's building a profile of our unique health profile or our unique health assessment that in their own right might be pre-diagnosing us with a probability that we might develop a particular condition, because they've gathered enough data over time that can reliably say, when do we need to go for that checkup, or do we actually need that procedure? So probably, say, 20 years, 50 years from now, it might be that we get an SMS or whatever it's called in the future, but a message that says our models have detected that you need to go see this particular specialist. And it might be that, when they're coming to the ward or that facility, that the right people are coming at the right time and being diagnosed at the right time. So I think that's an interesting scenario that I sometimes think about. What's your perspective on that one?
It's not so futuristic. It's being done. So in other hospitals, so when we started this journey, I think in 2017, we first wanted to find out what other people doing, because we're not unique. It's not that we suddenly thought of some special solution. And it took us quite a while to formulate precisely what we want to do. So we actually contacted a whole lot of hospitals in the States and overseas that are tracking patients. The technology they were using was old. Some of them were still using manual systems. And we still do watch carefully what they do and how they do it. And the current hospital tracking systems in first world countries focus on specifically patient journeys and outcomes. So they would look at one of the biggest banes of hospitals, and that's in South Africa too, is hospital-acquired infections. And we know that if patients stay too long in specific areas, in ICU or other high-volume areas, that their risk of hospital-acquired infections increase. And this is interesting data. So worldwide, a lot of work is being done around that, and we believe Sense could provide that kind of back data, especially where it starts integrating with existing records. And I think that would be really valuable, is once you can integrate a patient journey with their health outcomes. And you can actually say, because of this and this and this, we could isolate and identify areas that may be at high risk. So it's hospital-acquired infections. And the other one is fall risk. So patients falling in a hospital because they're frail and they're vulnerable.
Yeah.
This is a time when people are not at their best, and you slip and you fall, you break a hip, and it happens. But that's a devastating, I don't want to say complication, but that's a devastating outcome for patients. And if you can start predicting and managing that, it makes a huge difference in terms of resource management, in terms of costs, in terms of their specific healthcare income. So that integration with their health data would be very, very valuable.
And then I think, just say from me personally, to understand, say we all watch sitcoms like Grey's Anatomy and these sort of doctor shows, from the point of view, the unique point of view that you sit, say, within the operating theatre, how does it work? Do you sit with headphones while you're monitoring, what the patient, is he still asleep? Are they going to wake up? Do they feel the pain? Maybe describe to the audience, what does a typical day look like for you, when it comes, because as a person having the procedure, we'll never see that perspective, and I'm interested to find out what that looks like.
So we are the grey men of the healthcare fraternity, and we often, because of our personalities, enjoy that label.
Okay.
And I can talk from a perspective of our practice. I am still working as a clinician. We are very involved in the perioperative pathway of patients, and more that is an area that's growing in anesthesiologists, is perioperative medicine, where we're involved in assessing and seeing patients beforehand for high-risk procedures and high-risk patients, and to prepare them for procedures. And there's a concept called prehabilitation, which means preparing people for big surgery. It's still only for really selective kind of procedures. So we will assess patients. We will try and see them on the morning, depending on the logistics. And that brings us to our solution, is trying to find patients in the morning for an hour before this can be quite challenging. And also managing the beds in a way that all the patients are actually admitted before the theatre slate or theatre list starts is a challenge. So we focus very much on the perioperative communication, because as anesthesiologists we know, and no one remembers your name, and we're very poor at the perioperative communication. And so then we will have a fixed list for that day. We will anesthetize a patient. It is a complex science. It's not just the injection and you sleep. We use probably a combination of about 8 to 10 drugs for anesthetic plus a gas mixture. And every procedure is unique. Every patient is unique. There's no two anesthetics the same.
Wow.
And there are different times during the procedure where your attention is a lot more required than others, for sure. There are things that we do in theatre, like we do a lot of pain techniques. We will put up specialised monitoring lines and invasive procedures. We will manage the ventilation and the blood pressure of patients routinely during any procedure, but also goes wider than that. It's kidney function, brain oxygenation. So it's quite encompassing.
So you're keeping the patient alive while as being
I think it's a team effort. I'd like to say it's just us, but it's not.
Yes.
It is definitely team effort, and it's why it's so important to have well-qualified nursing staff who are absolutely invaluable in theatre. If that team runs well, it really speaks to better outcomes. So it's definitely communication between the anesthesiology team and the surgical team, clear communication, clear management of what we expect, and a thorough assessment of the patient and risk management. It comes down to the risk management. Definitely.
And you've described it before, especially from a South African context, is that we're not demand constrained in terms of new patients. We supply constrained in terms of medical practitioners. So if you're working with a limited pool of people, of highly skilled people that can do this, if the population is growing and the number of medical experts aren't growing at that same rate, there's an efficiency gap that needs to be achieved to even just keep up with normal day-to-day. So, I can imagine, if you can only, say, be in one operating theatre at a time, so the more efficient and sort of pre-planned you can be, the better in an ideal world. So what's a typical number of patients that you can actually or see in a day, or does it really, really depend on?
So it will depend on the procedure, absolutely, and availability of resources. For a cardiac theatre, we can probably do 2 bypasses in a day, which is 6 to 7 hours each. Whereas if you have ophthalmology lists, eyes, cataracts, that's short procedures, you can have a high volume or high turnover list. So it differs definitely on your level of expertise, because we all like to kind of focus on specific areas. Even in anesthesiology, we won't all do all kinds of procedures.
What's your speciality then?
I enjoy obstetric anesthesia. I do. And I enjoy.
So just for us simpletons, that's eyes. Huh?
No, our obstetric is maternity. Is pregnancy.
Okay.
So that's what I.
So that would be sort of C-sections.
And birth and in the postpartum period. We have smaller teams in our practice that do like cardiacs. There will be guys that are more inclined to do abdominal surgery. I'm from East London, so we are generally all generalists. We can do all anesthetics that we're required to do down there. But we won't do, for instance, liver transplants, and specialized stuff will be sent to the bigger centers where it's more protocol, definitely.
Yeah. And if you sort of want anybody listening today sort of to take away anything about, what Sense does and the value it provides, what would you want to leave them with that sort of could summarize, because you might, maybe from a patient point of view, we might demand more visibility, and that could encourage hospital groups to adopt technologies like Sense sort of more rapidly. So say if somebody's listening to this and about to go into a procedure and they had to sort of lobby for Sense, what sort of key things would you want to leave them with?
I think there's definitely a need for independent data, quality data that you can rely on. And our Sense product really, we worked very hard in providing a 90+% coverage, because if your systems are down, it's pointless. So you need key quality data, preferably automated, that you don't have to spend a lot of time and resources in analyzing. And that will enable you to have just better communication between stakeholders, between patients, between different areas of care. And I mean, that's low-hanging fruit for me, that takes away a lot of burden that we can really do without in healthcare in South Africa in a fairly easy way. It's not saying we need to train more doctors and nurses, but that has an order time of 10 years.
Yes.
While this is something we can do now.
And definitely. So I thank you for joining me today on the Insights Overflow podcast. I've enjoyed this conversation a lot and learned things that I would never have learned if I didn't. So thank you very much for listening. You've been listening to the Insights Overflow podcast, episode 6 with Jan Swanepoel. Thank you very much.